Excellent. We are live. This is episode 4 of To The Point podcast. I'm your host, Paul Kaloran. And today we have an incredible host, and we will try and focus our clinical discussion to dry needling safety and specifically some dry needling safety research. I'd like to introduce our guest. He's joining us from North Carolina. Dr. Andrew Ball is a physical therapist, DPT, also has his MBA and PhD. He's orthopedic certified. He has his OCS. He's CMTPT certified. He's also CERT MSK US and actually is an instructor for ultrasound imaging. He's certified in functional fascial dry needling, but he's also dry needling faculty for Myopain Seminars with Jan Dummerholt. As I mentioned, he's an ultrasound imaging instructor. He's a peer-reviewed author. Today, we're going to focus on clinical, so dry needling safety, but he's done everything from pediatrics to orthopedic PT and even voting empowerment. So really, as I said, almost every episode, I think I'm making it harder and harder to keep these discussions to one topic and to 15 minutes, but such an incredible host. He's also the vice president of Next Gen Institute, and he's a lead physical therapist at a general ortho clinic that works directly with the U.S. National Whitewater Center.
No, let me correct that. I work near the U.S. National Center.
Excellent.
Yeah,
anything else I missed? That's an impressive resume, sir. And thank you for joining us. Seriously, this is it's really exciting for me. It's almost makes me nervous, the amount of experience and the credentials that some of our guests are bringing to the show. So really means a lot to us and hopefully to the viewers that you're giving us 15 minutes of your time today.
Well, let me start by thanking you for putting this together. I think it's, these little kind of chunks and bites of information that people can quickly download and digest, and then have the opportunity to kind of dig deeper. And maybe have just one pearl that they come away going, I hadn't thought about that. Like, good on you, man. Good on you.
Thanks. That is exactly the intent here. So thanks a lot. So I will start our little timer shortly. And again, we're going to get into a fairly specific dry needling safety research discussion. But really with the guest of your prowess, I'd like to kind of paint the picture and ask, I really like to hear people's exposure story, meaning when did you first see dry needling? How did you, I guess, what training did you go through, but how did you implement it into practice? Because you specifically have been dry needling for a decade longer than most. Yeah. So I'll start by kind of asking that. What was your kind of birth story, your exposure to dry needling?
Well, I've always been somebody who wants to be a little bit ahead of the wave in PT, and my skill has been less of a clinician and more of being able to see what's kind of coming over the horizon. So I was among the first to do a DPT in the country, a post-professional anyway, DPT. I believe the first, or I was told that I was the first to do a PEDS fellowship. I was early in manipulation, but not the earliest. So I did it for two reasons. One is that I always want to separate myself ahead of the pack, because frankly, I'm not interested in or that good at marketing. So I'd rather folks have to come to me because I'm providing a skill that nobody else in the state or region or state is able to do. And dry needling offered that. So that's the selfish reason. The reason that I was interested in bringing it to the masses of clinicians, the rank and file clinicians, was because no matter how good you are, there's a section of patients that you just don't get better. For me, I had just completed the first residency, orthopedic residency in North Carolina at Atrium Healthcare. And very quickly, I felt like there was something missing. I felt like with manipulation, when folks finally get that, they're like, oh, now I have a skill that sets me apart. but it really kind of jump starts the ability to get someone to kind of break through that discomfort. And now I can get to the neuromuscular re-education. Now I can get to the strengthening. Now I can get to the agility. And dry needling just seemed like that little piece where I felt like I feel it there. And when I press on it, that creates the patient's pain. If I could just stick a safety pin in there, then I feel like I could solve the patient's trouble. And what I then did is I looked around to see who was teaching dry needling in the United States. And at the time there was Myopain Seminars, Kineticor was teaching, and Yao Ma was teaching, which I think is now integrative dry needling. And then knowing that there would probably be some degree of friction with acupuncturists at some point, I felt really strongly that I should pull together people that I thought were among the best and the brightest in North Carolina to do that first cohort. So the fellows, the post-professional DPTs, of which there were very few, the PhDs, those folks. And we put together 12 people, and we started looking around for what course we wanted to bring into North Carolina. And it was very, very clear after looking at kind of where either intellectual property kind of came from or what was furthest away from what could be misconstrued as repurposed acupuncture. You know, everything fell off the table other than Myopain Seminars. So that's why I decided to do that. Not to mention the fact that Dr. Damerol, Dr. Orlando Mayoral in Spain, and there was a third, and his name escapes me at the moment, were the first to really create a lot of these techniques. So if I could get him here, you know, what better way to go as a foundation.
Yep.
And then to kind of build off into these kind of other approaches. But it was an uphill battle. I mean, first with colleagues, it was not, the question was interesting. It wasn't, how is that going to help you get your patient better? The first question was, are PTs really allowed to puncture the skin? I don't think they're allowed to puncture the skin. And then it was, very quickly, it was, well, only elite therapists puncture the skin and do trigger point dry needling. And within 5 years, it was, well, you know, the guy who used to do the dry needling in my clinic left and went to another clinic, and we had $300 worth of needles, and I feel like I should be trained. So it's really hard now to call yourself an orthopedic or sports therapist and not have at least one of these styles of needling under your belt. It's very difficult to attract patients if you can't do it.
Yeah, I agree. And that's exactly kind of the picture I wanted to paint. Is right now, I think we can say we're past kind of early adoption, and dry needling is mainstream, meaning there's not really a state or a clinic that doesn't have some type of needling in their their outpatient physical therapy clinic. So yeah, it's exactly kind of the picture I wanted to paint, because you even brought in the fact there are still states, I'm sitting here in Washington, where the friction between acupuncturists is high. And one of the arguments that they always bring forth is safety. So that's my segue into our more specific topic. You were the primary author of the relative risk of the femoral nerve, specifically as a function of patient positioning, and really the tactical implications for trigger point dry needling of the iliacus muscle. It was in the Journal of Manual and Manipulative Therapy. Some of those other big names you mentioned, Jan was on the list of authors, Shane Copenhaver, Orlando Mayoral, or Del Moral. So it's a very intriguing.
Carl Braun, let's not forget him. He was one of the earliest of adopters. I don't know if he was one of the original three, but I think he was very, very close to it. And everybody knows the name Cesar Fernandez de la Piñas, right? Yeah. He was actually trained, I believe, by Orlando. So that's where he got his training from.
Yeah. I mean, Cesar de la Peña seems like he has dry needling research released every week. I mean, it's an impressive volume of research.
Yeah, last I looked, he had 1,800 articles or something. I've got 10, and we graduated with our PhDs at the same time. He's a machine.
Man, that's incredible. So with that title, I mean, really just go into what was the hypothesis or the research goal, what was the methodology, and ultimately what were your research conclusions for this specific publication?
My research goal was really to put together a think tank across multiple continuing education companies that could be utilized to from across the world to begin to look at dry needling issues, dry needling safety issues in particular. And the reason that iliacus was chosen, one was because it was easy to do logistically and from an imaging perspective. One of the things I really wanted to look at was psoas and the landing of the needle, and doing that with ultrasound is technically more difficult. So I kind of pulled back a little bit. And then the other issue was, let me look at a postural issue. Let me look at two different postural positioning techniques that nobody in any continuing education company really has any kind of political affinity to. So there were some instructors that were saying, I prefer this technique and here's why I prefer it. And then there were others that were saying, I prefer this technique, but nobody really had any strong opinions about it. Myopain Seminars, we used to teach both positions. You can do it in supine, you can do it in sideline. The hypothesis was that it really doesn't matter. And as it turns out clinically, you can argue, does 3 millimeters really make much of a difference clinically? And that's reasonable. But I would argue that the discussion is a larger discussion, which is, do little things like postural position of the patient or support of the pillows, support of the patient, slight differences in our intended needle direction, does that make a difference in safety? And even if it's 0.01% of safer to use one technique versus another, shouldn't we always stack the deck in our favor as far as safety is concerned? And that's the message I would like to push forward, is even if it probably doesn't matter, even if it might, even a little bit, we really should be sinking into a deeper level of clinical reasoning when we think about safety. And I'll pause there because I'll bring up a quick story between you and I relative to that.
Yeah, I think those are great points, because honestly, I was trained in the supine position. I do it in both. And honestly, why I use which position is largely based on what else I'm intending to treat, meaning my initial thought wasn't how it impacted safety. But I agree with your point. That is, anything that will improve that 0.01% risk profile is worth it. And that's really exactly what you were looking at with this one. And sorry to go off of the script, but when our discussions this week, we even brought up some multifidus safety research, both safety, but like consistency, accuracy, landing on a spinal lamina.
Yeah, so I can go into that. Look, way back in the day, there were 3 providers basically across the country. And, some folks will with different levels of creativity, will create their own like intellectual property based on either acupuncture and kind of bring that into what's more physiotherapeutically biased, or we'll take the work of the originals and kind of mix it with something and kind of create something new. And that's great. But there still, in my opinion, needs to be a recognition of the clinical reasoning that led to why is that approach the gold standard. So we talked about some research that was produced in 2016, and it was someone who really hasn't been needling all that all that long. They became exposed to it, I think, in 2014, and took their first course, I believe, with the group that you're trained through, in like 2014 or so.
Okay.
You don't get to claim that 10 years of experience. And one of the and that is now teaching some courses. So is trying to create my own or her own intellectual property, and I get that. So one of the things that was done was exploring, looking at the multifidus, and instead of using that inferior medial technique, why can't we just use the straight in posterior to anterior technique that, frankly, quite a few electromyographers will use, and they think that that's safe. And what they did was they looked at a cadaver, and they said, okay, how many times when we attempt to use this technique do we land on the lamina and know that we're safe? And it was 8 out of 8 times. So getting back to that clinical reasoning and the safety, that was never the reason really why that technique was chosen. The reason that an inferior medial technique is chosen is so you don't slip in between the lamina, right? Yep. And cause an epidural hematoma. Well, a cadaver is not going to ever present with an epidural hematoma. So I don't care. And this gets back to our earlier discussion that we had way back when. What's the number one issue or number one variable that should be considered with respect to safety? Is it anatomy? Is it who you train with? And yes, those are some variables, but the number one is you got to think. You got to use your clinical reasoning. And if you see a paper that comes out like that, it's a reasonable paper. I can't take anything away from it, but it doesn't really address the issue of the epidural hematoma. Now, does that mean you should never use it? No. What if you have a patient who has a laminectomy? You have to use a different technique. But to say that all techniques are equivocal just because that's the one that you're pushing, I have a problem with that. I think that we could and should be better as a profession.
I am in full agreement with that. Thanks for, I guess, not just agreeing with me, but for saying that. We're almost up to our time, and I actually want to go a minute or two longer if you have the time.
Yeah, sure.
But really, let's toss a question in for really the beginner, the novice needler. This is something you hear consistently on your level 1 to level 2. Everything is knowledge of anatomy, how to treat efficiently and effectively, but also how to avoid those sensitive neurovascular tissues. Mm-hmm. So the question is, what if? So what if our needle does interact with the femoral nerve, the femoral artery? What's kind of your answer to that novice clinician that says, what happens?
I'll give 2 quick answers. The first is when I became certified, it was 5 courses. The last one was a week long, and we would spend 8 to 10 hours with Dr. Dameralt and a lab assistant, and then we would have dinner, and then we'd all study together for the final exam. And at some point, you're going to be tested on Friday. You've needled everything you're going to needle. You've studied everything that you're going to study, and you start to kind of question things like, what does it feel like if you hit a nerve?
Yep.
The only nerve that we were able to consistently hit was the sciatic nerve. So I would say that. So that's the biggie that you want to be aware of. There are some acupuncture techniques where you actually go after a nerve. You try not to puncture them, but you try to get very, very close.
Yep.
So I find that unnecessarily uncomfortable. I don't want to have it done to me. I don't want to do it to somebody else. It's not a huge deal to touch a nerve. It's a huge deal to pound on a nerve 137 times when you didn't intend to hit it the first time. So, if, I would say to the novice needler, if you hit a nerve, what you don't say is, oh my God, I hit a nerve. What you say is, okay, that may have been a little uncomfortable. I didn't get a local twitch response there. But clearly, we touched something significant. Let's back up. Now I know where the nerve is. Let me just not hit it again.
Right.
And it's normally not the large nerves. It's like collateral nerves that you may touch. They don't want to be touched. Yeah. They're like your kid brother when you're in the station wagon going on a long trip when you're a kid, and you get close to the nerve and it's I'm not touching you. I'm not touching you. I'm not touching you.
Totally.
As long as you don't tap in and just hack away, as long as you needle with intention, the anatomy is important. You've got to palpate. And I believe that specificity is super important, because what we don't want to do in terms of safety, in terms of soreness, is to palpate with the needle any more than we have to, right? It should be maybe 1 or 2 sweeps of feeling through the needle, and you should get that twitch response if you're doing trigger point dry needling. You don't tap in and start hacking away. And as long as you do that, you're going to be okay.
Yeah. And I think you bring up a lot of key points, because I think, again, in that novice's mind, it's, if there's any unintended interaction, that's an immediate an apology, and almost like catastrophizing in your head, like, what did I just do? So I think you bring up the very important technical aspects of, there's a very subtle way to approach sensitive tissue versus aggressively or multiple times. But honestly, that conversation, communicate, and even the words you use is almost as valuable if you have a sensitive interaction. Because I agree, it's the peripheral, the cutaneous sensory nerves that speak the loudest. And not to be aggressive or crass, but those are kind of the ones we worry the least about compared to like our large motor nerves.
Yeah. Honestly, I think it's more of a mindset. The biggest quote unquote safety issue that I see is folks who get their hands on needling, and then the following weekend, they want to be immediately insta famous. Right. And, and I can't police everybody. And that's how you and I began interacting. I'm not trying to police people. I don't have time for that. But every now and then I see something that's pretty egregious looking. Yeah. Needling outside of fingers. And we can have a debate as to whether or not that's necessary or not. But what is not debatable is if it looks like you're needling like the upper trap toward what could be an apical lung, don't put that on Instagram. Even if it looks like, even if somebody could debate it, don't leave room for acupuncturists. Don't leave room for our brothers and sisters in arms, in California and Washington that want to do dry needling. Throttle back a little bit. Become good in the clinic before you become good with your dry needling marketing. I thought long and hard about what answer I was going to give about what's the number one safety issue that I would give, and it would be humble, have respect for what you're doing. Don't be fearful, but have an understanding of the anatomy, and don't try to use it as a marketing tool before you're able to use it as a clinical tool. I think that's the biggest safety issue that I'm seeing. And that doesn't matter who you're trained by.
Yeah. And it's interesting. I've been reading skill acquisition research, not specific to needling, but it's interesting that someone learning a new technique, again, it's not talking specific needling. You could probably apply this to manipulation or anything else. That novice is much more risk adverse, meaning they're much safer probably with their application or even deciding how and who to use it on. So that data almost suggests that it's the more experienced clinician that becomes a little more cavalier. And to some degree, when you start losing that humbleness you just mentioned, maybe you have the potential to cause more harm. That's an interesting point.
That's an interesting point. I'm talking about the long tail. I'm talking about the cowboy who's got the kind of practice where they need to immediately show that that they've got the new toy on the block, and those are the folks that are really good with marketing. I don't know how good of a clinician they necessarily are. They may not be bad, but if you can destroy someone else's business, or you can destroy the ability of some of these other states to ever get dry needling, I think that we have a greater responsibility than just putting up a quick video to get patients, especially, and I'll give another plug, in the age of COVID. I think we have a responsibility to do some things other than our own marketing and other than just workouts for people who were stuck in their homes. I think that we have if it's a calling, it's a calling. And I think we need to step up.
Yep, I think that's a great way to end. And thank you for policing as much as you do. I know you and I have gone back and forth. Like, we repost a lot of stuff and we put our best to put a filter on it. But one of the things I love about you is you will just call someone out and call it what it is. And that's how we kind of interacted on that first time. But
well, I try to do it
and you elevated our bar. I mean, you definitely upped the threshold of like, we need to be a little more discriminative of what we are actually reposting. Because honestly, I agree. There's even people we've trained, people we know, and you just see stuff on social media that if it looks iffy, I'm completely with you that it shouldn't be out there.
Yeah, we just need, if we're going to hold chiropractors to policing themselves and physicians to policing themselves, we need to do that. And we can wreck our profession really, really quickly with well-intentioned bad marketing. Yeah. And I really appreciate the interaction that we've had since then. You are absolutely a leader in the profession, and keep on doing this.
Well, it's being the dumbest one in the room. Like people like you, it's
you're the smartest one in the room, then you're in the wrong room.
Yeah, I like that. We are way over time. So first of all, thanks for sticking longer than you might have intended. I'll wrap things up. Next week, we have Sue Falsone. The week after that is November 4th. We have Jeff Moore. So we're just going to keep just the power players coming. And I will always do my best. We're at 23 minutes right now, but I'm going to do my best.
Sue a little bit.
What's that?
Can I plug Sue? I know Sue fairly well.
Totally. Yeah, go for it.
So one of the things that a lot of novice therapists are looking for is who should I learn from? And what I would say about Jan and Sue is that they're two sides of the same coin. The way that they needle is diametrically complementary. It's very, very different. One is trigger point. The other is more of a Western biomedical dry needling type of approach. The best needlers that I've seen, people like our common friend Will Freris, yep. They have learned from and become fully certified, and that's the other issue, in multiple types of dry needling. They are the folks that are going to lead in the future. Yeah. So if you're looking to get into dry needling, it ain't just one approach. Learn them all.
I agree. Thanks. And that's part of my selfish endeavor here, having folks like you, Sue, on, is I want to educate myself and expand beyond just a single training. So that is part of the, underhanded sounds negative. That's kind of my selfish effort here as well.
Please give her my best.
I will.
My favorite people in the profession. I really like her quite a bit.
Drew, thanks so much for your time. I really hope to have you back to talk any of the other topics that we could, but
anytime, man, anytime.
One of our first 4. So thanks a lot for helping us kick this off and for your time today.
Sure. Edit as you'd like.
All righty. Thanks, guys. See you next week.